Good morning, everybody. My name's Kara, Kara Segna, and I work with patients in pain all the time. I'm an acute pain expert at Johns Hopkins, and I think about pain every single day. Even when I'm off work, I get called about pain from literally everybody, and I'm sure that this is very common in this group. So I'm very grateful to be able to speak with such a diverse group of people today. I have no conflicts of interest. Today we're going to talk about what pain is, how to measure pain in patients, and multimodal strategies to treat pain. And as I said, everybody in this room has dealt with pain before in themselves, will deal with it again, will have a child, a family member, a friend who will have pain and will look to you as a healthcare provider to help them. So there's two kinds of pain. There's acute pain and there's chronic pain. And acute pain is a noxious experience with sudden onset, short duration, and it's clearly associated with a cause. So you put your hand on the oven, ouch. And it's referred to as a fifth vital sign because hospitals very much push treating pain for patient satisfaction and recovery and for discharge. Chronic pain sometimes is a disease state. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And it's defined as pain that lasts, if your pain that you have lasts over 3 months. Now, that's not necessarily true. It's a lot more complex than that. It has to do with neuromodulation in the spine and actual physical changes. But it's a really great point to think about. After 3 months, we are now in it for the long haul. We have to start thinking bigger than just giving oxycodone or Tylenol. So there's 3 categories of pain per the CDC: type 1, which is mild, type 2, medium, and type 3, intense. And it's related to what kind of what kind of surgical procedure you're going to get. So like a pain that should be 3 days or less would be like a appendectomy, and pain that might be up to 2 weeks would be a spinal cord fusion or any type of bone surgery. In my experience as an acute pain attending, I have found that the first 24 hours are the worst for the patients. So I really aggressively treat their pain when I first meet them, and I set my expectations. I'm like, day 1 is bad, I know, but then it's going to level out. We got to get through day 3. It's going to decrease, and then it's going to level out, and then we're going to get to day 5, and then it's going to decrease again. And it really helps my patients if they have some kind of idea of what to expect. Telling people that you're going to have no pain is probably a huge disservice to them because there's no such thing as no pain. That is a coma. But if your expectations are set appropriately, it's extremely helpful. And for me, that appropriateness is, can you get out of bed to go to the bathroom? Can you eat? Are you able to sleep at night? That is my goal. That is what is going to keep you going, not this number. I need you to be a 1. I don't believe in that. So when you are going to start doing your comprehensive pain plan, the first thing you really got to do is you got to talk to your patient. You got to establish that rapport and that trust. And I always sit down. I want my patient to know I have time for them. And I look him in the eyes. I'm like, I really want to help you. We are a team. It is not me telling you what to do. We have to be together on this. And that's how we're going to get you through this terrible time in your life. Because if you're seeing me, like me specifically, this is not a good day for you. I am what they call the big gun in the hospital. If somebody has pain refractory to typical medications, then they call me. So I want my patients to know I'm here for you. We can get through this. You have to also understand their pain history. What caused their pain? How long has it been going? What have they been taking? Importantly for me, if you've taken pain medicines before, what has worked and what has not worked? Because if you've taken Dilaudid pills in the past and they worked, but oxycodone and it did nothing for you, I don't want to reinvent the wheel. I don't want to lose my days guessing. I will just go straight to the one that worked. Assessing pain behaviors. So this is a good one because everybody, if you walk into a room, you can tell if someone's in pain or not most of the time. But before I really started to understand pain, I would see someone playing on their cell phone. I'd be like, oh, they're just playing on their cell phone. they're not in a lot of pain, or they're playing on their video game. That isn't necessarily true, because part of dealing with pain, like, is you have the pharmacologic part, but you also need the distraction part. So if you are in pain, you can try this the next time you have a headache, or something is going on that is not uncomfortable for you. If you watch TV, if you play on your phone, you can at least put your brain in a different mentality, and that will help with your pain almost as much as the medication. Almost. Together, it is key. You should use validated pain assessment tools. I'll show you some. And you should address cognitive and communication challenges. So that's if somebody is intubated, speaks a different language, doesn't trust any healthcare providers, like for example, the transgender population has a real hard time with healthcare providers, or certain other cultures will have a leader in their family, and they only want to talk to that person, and they help make decisions. So collaborating with the patient and their caregiver is also a really big deal. These are 4 examples of pain assessment tools. The one in the bottom left is a very common one for the hospital, 1 to 10. I think it's okay. I don't treat it like the word of God. I use it just to track. So are you 5, 6, now you're a 10, or were you a 10 and now you're a 2? So I just kind of follow. I just use it as a tool. I really like the Wong-Baker faces. That's the one on the bottom right, because it doesn't matter how old you are. You could be 2, you could be 100. I see a lot of 100-year-old patients. Everybody can point at a face. You can speak English, you cannot speak English. It's just, I like it if we really need to get to the bottom of a pain assessment. There's also the behavioral pain scale. I'm sorry if it's a little bit fuzzy, but it is rated 3 to 12. And I use this, the nurses use this, and I really am grateful for them when they are doing their pain scores. And they look at the face. Is it relaxed? Is it grimacing? They look at the movement of the upper limbs. Are you not moving, or are you completely retracted? And vocalization. Are you saying you're having pain? Are you making grunting sounds? Or are you just, every time someone touches you, do you yell ouch? And I take the behavioral pain scale with that numerical pain scale, and together I make my decisions for moving forward when talking to the patient. So here's just a question. According to the World Health Organization, in which order should pain medications be escalated for a patient? I'm just gonna do a 10-second countdown on my timer in front of me. Give you a chance to read it. Okay, the answer for escalation in pain medications would be A. You want to start with your non-opioid, and then move to your weak opioid, and then your opioid, when you're at least trying to build your level. So this is the World Health Organization ladder of pain control. It was created in 1986 to help address cancer pain. And the mantra of this ladder is by the clock, by the mouth, by the ladder. So by the clock, that means that you need to consistently be dosing these medications, whether it's every 4 hours or every 6 hours. Don't let it get too long, because then you'll get behind, and that's a whole nother lecture. By the mouth, a lot of my patients don't believe me until I convince them to give me a try. But oral pain medication is king, not IV, not IV. IV kicks in fast, but it goes away fast. So you might feel comfortable, and you finally get to take that nap that you desperately need, but then it's gone, in an hour or an hour and a half. The pills will take 40 minutes to kick in, but then they'll last 4 to 6 hours. So you actually get some prolonged relief, and you can sleep, you can walk, you can eat. So that is everything. And then by the ladder, is start at 1, move to 3. So a multimodal pain approach, I'm sure everybody has heard that. It is like a buzzword now, multimodal pain. The whole point of the multimodal approach is that there's lots of different pain receptors in the body, like COX and mu and NMDA, everything, CBD. But certain doses of medications, you're going to get pretty bad side effects. Some of them can be pretty devastating, like respiratory depression with opioids. So the goal is to use smaller doses of a bunch of different medications so that you avoid the side effects, but you're able to hit the pain receptors. And it's not just one, we're going for all of them. So that is why this is such a better approach for people who are in pain. So you have your pharmacologic interventions, your non-pharm, like your, sometimes people have the VR goggles, or they listen to music, or they have like essential oils, which in theory could be in both. And then they have their tailored pain plan based on what they took at home, whether they took anything, and what has worked in the past. So true or false, narcotics are not a part of a multimodal therapy pain plan. The answer here is false. Narcotics are very important. I know we want to limit it. I know narcotics are bad, but there is a time and a place where they are absolutely appropriate, and you definitely should consider using them. And one of those times is right after surgery, in the PACU, in the first week after you are injured. And just a little, I sometimes go on tangents, but I will have patients who will refuse to take narcotics after major surgery, like spinal fusions. And the reason is because they're so afraid, because they had a brother who had addiction and died, and they don't want to like put themselves at risk. And I have to sit down and be like, and have my appropriateness conversation, how this is not forever. It is just right now to get you through the first couple of days. If we don't treat your pain, things can get a whole lot worse. If you don't walk, you'll get DVTs. If you don't eat, you'll have nutritional issues. Like we need to get you moving. We can't get behind. And I have that conversation where I validate, I know your concerns are real, but you're in a situation where we really have to focus on you and getting your healing going. So this is just a little chart here, multimodal approaches that I consider. So I also happen to be a nerve block specialist. I've been doing it for 9 years, and I was a fellowship director for a long 8 years. So that's my favorite thing. I love nerve blocks, and I love putting in catheters and epidurals. Very, very useful tool, because there's almost no side effects to taking out somebody's limb to help with the pain, and the pain does go close to zero. But they wear off, and if you aren't taking your multimodal pain plan, you are going to be in the worst pain of your whole life. And that's one of the things I talk to the surgeons about, like, hey, I'm sitting with your patient, I'm giving them my pager number if something goes wrong, and I am physically telling them, yes, you are gonna wake up from surgery feeling like Superman because I took out your arm. But when that wears off in 12 to 24 hours, you're gonna be in a hellscape. So you gotta take your pain pills before you go to sleep. So we've got the nerve blocks, we've got, if someone has a spinal cord stimulator, that's chronic pain, but like it's, we want to keep it going. NSAIDs, muscle relaxants, opioids, and NMDA antagonists, that's your ketamine and your magnesium. Local anesthetic infusions like lidocaine, if that's something you have access to, gabapentinoids, and then of course education and communication. And I know a lot of people will say they don't have a magic bullet. I do. The magic bullet in acute pain is muscle relaxants. I promise. That is the one thing that nobody thinks about treating for. And when I get my desperate calls from various teams in the hospital, I show up and I ask the patient, like, what does your pain feel like? Is it sharp? That's going to be your narcotics. Or is it dull and throbbing? That's going to be your muscle relaxants. Does it constant? That's your narcotics. Is it come and go randomly with like absolutely no rhyme or reason? That's your spasm. Your muscles are spasming, they're pulling on that surgical site, and they're causing that sharp pain. So I start everybody, and I have a little slide on it, I'll go over it, but muscle relaxants are like the most underappreciated drug that is used for pain. So multimodal regimens, they improve patient satisfaction, it's better pain control, it's potentially shorter hospitalizations, as I mentioned, it reduces side effects, and it could decrease tolerance and diversion because you don't need as much narcotic. I spoke about the regional nerve blocks. You've got your epidurals, your truncal blocks, so that's your tap blocks, quadratus lumborum, erector spinae, and perivertebral. You've got your lidocaine infusions if someone has like a big belly case, but they are not an epidural candidate. And then, of course, our lovely surgeons who can do surgical field infiltration. So IV lidocaine. So lidocaine reversibly inactivates fast-gated sodium channels, and it blocks the pain impulse. And it improves analgesia while decreasing opioid consumption, which is the goal. And because you can decrease those opioids, you can have a potential improved return of your GI function. It does not inhibit the neuroendocrine response, and it's really great for like soft tissue pain or abdominal pain. It mimics an epidural, which is wonderful. And the way that I use it in the hospital is I will run it at 1 milligram per kilogram. I typically don't do the bolus, even though that's very common. And then I'll get a lidocaine level every 24 hours. And even my levels that show that I am not in a therapeutic range, I'm below the therapeutic range, I still have incredible return on my pain improvement with patients. I've found it doesn't have to be therapeutic. So I go low and I increase if I need to. At Johns Hopkins, we run our infusions for 48 hours. But I've spoken to many colleagues at other institutions, and they'll run it for up to 10 days. You just have to be careful. You got to watch your liver. You got to keep on top of your lidocaine levels. So good old NSAIDs. These are wonderful. I really get sad when I can't give it to somebody because we're worried about bone healing or they have bad kidneys, because it's excellent. My favorite NSAID is Toradol. It seems to be magical for everybody. Other common ones are ibuprofen and however, one more thing to avoid, I forgot, Beer's criteria. Beer's criteria is a gigantic list, of medications that are potentially not a good idea for the geriatric population. And unfortunately, everything is bad for the geriatric population because they're just so complex and they have comorbidities and they have lots of medications, and it's very difficult. But I still treat them. I just lower the dose significantly, and then I watch them. Tylenol, acetaminophen, there's oral and there's IV. It's theorized that it works as a cyclooxygenase inhibition, but it's not confirmed. Just got to be careful. I know we all know about liver toxicity. Try to keep under 4 grams in 24 hours. And keep in mind, it's sneaky. It sneaks into other medications. So we got to look at all forms. My muscle relaxants. Back to my silver bullet here. So what they do is they inhibit nerve signals that contribute to muscle tension, allowing for reduced muscle activity. When I see patients at bedside, I will physically see their legs spasming. And sometimes I don't see it grossly, but when I'm looking with my ultrasound, I'll see very fine fibrillation of the muscle, and I can tell that they're in pain. It's actually kind of dangerous for me to do a nerve block because they just keep spasming and it keeps moving. My favorite muscle relaxant in general is Ribaxin or methocarbamol. It's a skeletal muscle relaxant because anything you can do to take pressure off of a patient from thinking, like standing drugs versus you have to ask for drugs, anything you can put standing is going to be very helpful because they are just not in a state to set alarms all the time and have to remember to ask for pain medicine. So methocarbamol, although it does say it's sedating, I have found that it hasn't been that sedating. And I do use it in the geriatric population, even though it's on the Beer's criteria. I just do a really low dose, 500 milligrams. IV Ribaxin, you got to worry about the kidneys, but oral, not as much. Valium is amazing. Amazing. If you have a patient who can take Valium, it is my 2 birds with 1 stone, because pain is not just, I'll just use the belly for example, it is not just where you got cut, it is so much in your head, and you can't believe this is happening to you, you're in pain, you can't move, why me? The catastrophizing really ramps up that pain, and then they don't sleep. And pain gets worse at night. I don't know if you all realize pain is worse at night. It has to do with a hormone, circadian rhythm, and sleep interruptions in general, because in the hospital people are getting waken up for all different things, not just pain. It makes it all worse. So Valium does cause sedation. It will help you sleep. It will help with the anxiety, and it will help with muscle spasm. So if you have a patient who can take like a very low dose, like 5 milligram PO, it's a game changer for them. But there's other ones as well. Flexeril, I am not in love with it. I know our neurosurgery friends use it all the time because it's in their literature, but I have found it does not help that much with pain compared to the other ones. Tramadol. So tramadol, I'm not sure if you guys prescribe it or not prescribe it. It is very quickly in the pain world, my world, being called tramadont because they don't want you to use it. It's level 2 of the WHO ladder. It can cause sedation. It can make you fall down. If someone is taking psych drugs like serotonergic or like SSRIs, SNRIs, it can lead to serotonin syndrome. But I still will use it in the appropriate patient. I'll do something low, like 25 to 50 milligrams every 4 to 6 hours as needed. It does have a tenth of the potency of morphine. So gabapentinoids, these are voltage-gated calcium channels in excitatory neurotransmitters. They're used in neuropathic pain. So that's your like just nerve pain. It's not sharp, but it's shooting and it's burning. And we have, in general, I think we are prescribing this a lot. It can cause people to be very tired. So when I am initiating this medication, as part of my multimodal plan, I will use very low dose, 100 milligrams. I will try 3 times a day. If that is too much for people, I will just put it at night because that is where making you tired is helpful for me because I really need you to sleep. So I'll start with the 100 milligrams just once at night, and then if you can tolerate that, I'll do the 300 at night. It can help reduce opioid tolerance and decrease central sensitization, and we can't use it in the elderly or on people who are on sedatives. It can just make you extra tired. So NMDA receptor antagonist, ketamine. Ketamine is a great drug. It is good for geriatrics. So this is the one drug that is not getting slammed by the Beers criteria. And I can tell you, I think it works great. I love using IV ketamine for my patients who are strict NPO and can't take anything else and can't get a block, or for my geriatric patients where I just got to get them through the first couple days. I typically start this at 0.1 milligrams per kilogram. So if you're a 70 kilo person, I'll start it at 7. Ketamine can cause hallucinations and bad dreams, and it can give you nystagmus. It can make you feel a little bad. So I start low. And on my older folks, I start even lower. So instead of 7, I'll start at 5. They just seem to be more sensitive, but it helps significantly. Ketamine is a godsend. When the hurricane took out Puerto Rico, we lost our ketamine, and it was very, very difficult for those patients that have extremely complex pain. Opioids, important for pain management, but we want to use it sparingly. And we have to understand that people are afraid of these drugs. There's the opioid crisis, and every other day you see something about how bad it is for you and how it's addictive, and you've got to be careful. So there's people are afraid of these drugs, but it is critical to use at the right time. There's the most common ones are morphine, Dilaudid, and fentanyl. I don't like morphine because it makes you itchy. I like Dilaudid because it has that nice moderate lasting, and fentanyl, I like it in the operating room because it's fast. I need it to be fast, but it also goes away fast. So I find it pretty useless in the post-op unless you're using it in a continuous infusion for something like an intubation. Narcotics cause problems. The mu receptors are not just in your spine, they're also in your GI system. And when they fuse, they shut down your intestines. So all that beautiful peristalsis and forward movement, instead of moving forward, it just goes back and forth like this. So everything stays and you get constipation like you wouldn't believe. It also can make you nauseous. It can cause a respiratory depression, and if you are on it for a very long time, can lead to tolerance dependence and addiction. The opioid tolerant patient. So this is somebody that if you identify, you're doing your pre-op or you're sending somebody to surgery, it's really important to know about them so that we can like in the pre-op area, start sooner. I want to give them Tylenol, Lyrica, and Celebrex. I want to consider a nerve block or a lidocaine infusion or a surgeon block. I want to think about ketamine in the operating room. This is somebody who is going to struggle. And also, it's really good to know what they're taking at home, because I have found when I'm called to like intense pain scenarios that when you start just your standard pain medicines, a lot of times it's like half of what they take at home. So you're not only not treating them, but you're also putting them in withdrawal. So it's very important. What do you take at home? Let me start that at minimum and then put a little bit more. Oh, and I'm going to talk about buprenorphine and Suboxone later this morning. And methadone, don't stop it. Just keep it going. This is about alternative and complementary therapies. This is not the slide I wanted to put here, so I'm going to talk about the slide I wanted to put here. Is it next? No, it's suzetrigine. That is the brand new drug that has been FDA approved as of like 16 days ago. It's a sodium channel blocker in the periphery, and they did a double-blind trial for people who had abdominoplasty and bunionectomies, so bone pain and soft tissue pain, and it was excellent. It really decreased pain. They used it with NSAIDs. It is not available until March. Then it should be in many major pharmacies around the country. But I'm very much looking forward to having one of the first new drugs on the market in a long time that's not a narcotic, that it has potentially low addictive potential because it doesn't affect the brain, it just affects the sodium channels in the periphery, so I'm very, very excited about it. And suzetrigine or Jornavax, I will make sure that my correct PowerPoint is uploaded. But it's brand new. It literally 16 days ago, brand new. So building a better pain plan. Utilize your local anesthetics. Use judicious use of your narcotics. Use your non-narcotic pain medications. Motivate your patient to get out of bed. That is so important. Like when I see my patients moving, I know that they're gonna do fine. Be mindful of the drugs that you give in the pre, the intra, and the post, because it all affects the patient. And the sooner you can get started, the better they're going to do post-op. Patient education is part of the pain plan. You want to set your expectations. You, like I mentioned earlier, you want to talk to the patient, you want to talk to their family, and you want to basically, like I said, tell them there's no such thing as no pain. Let's work on this together, and then involve the caregivers. And one of my last questions, you have a healthy patient with chronic pain and they're post-op from major abdominal surgery. Which of the following is the best pain plan? And I'll give you 10 seconds to look at this. So the answer is C. We restart our home medications, and then we, like I said, we do a little bit more. A dilaudid PCA is really great for the first 24 hours. What I do is I take that information. First of all, the PCA gives a patient a sense of control, and it just psychologically helps with that catastrophizing. They don't feel like they're bothering a nurse, or the nurse isn't coming soon enough, or whatever the catastrophize is. It gives them a little bit of control. They're happy. After 24 hours, I quantify how often they were hitting their button, how much they used, and then I can use that to convert to pills. And there's a lot of different conversions that are available for you. Gabapentin is a good choice, just for that multimodal, different receptor. And then of course, good old Tylenol. I would definitely add that as part of my multimodal. I'd probably slap on some lidocaine patches as well. Thank you so much.